All right.
All
Good morning, everybody. Happy Friday. It's 9:40, and got a beautiful weekend in front of us. So, Ruth, let's get started.
right. Well, welcome to Friday Chalk Talk. My name is Ruth Payne, and I'm a chaplain at St. Luke's, and I'll be your moderator today. Our presenter is Dr. Uzma Sabi, and as you can see, her topic is understanding complexity in palliative care. So I want to tell you that Marty sent me an article ahead of time on complex adaptive systems in palliative care to help give me kind of some foundation for this talk. And so I read most of the article, but it was tough to get through. And so I'm really looking forward to Dr. Sabi's ability to kind of open this up for us and help us understand more. So today's format is we'll start with the PowerPoint presentation, and then we will open it up for discussion. And so we ask you to remain muted during the presentation, and then afterwards you can unmute when you have questions, or you can throw questions into the chat. And so without further ado, we welcome Dr. Sabi.
All right, thank you everyone. Good morning. All right, so the topic today is understanding complexity in palliative care. And we all know that how complex our patients are. So I kind of reviewed an research article, Understanding Complexity, the Palliative Care Situation. And it was kind of, they had it, I should say, function through a complex adaptive system theory. So, the concept of complexity is used in palliative care to describe the nature of patients' situations and the extent of resulting needs and care demands. However, the terms or concept is not clearly defined and operationalized with respect to its particular application in palliative care. As a complex problem, a care situation in palliative care is basically, characterized by reciprocal, nonlinear relations and uncertainties. Dealing with complex problem necessitate problem-solving methods tailored to specific situations. And the theory of complex adaptive system provides a framework, basically, for locating problems and solutions. So, excuse me, I think I have to close this. All right, okay. So when we start our slide, so WHO, they have a definition for palliative care, and that is palliative care as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, spiritual. And internationally, there is no uniform way to describe different levels of palliative care, but there are two levels of palliative care. One is basically generalist palliative care, which provides the primary care in community and hospital, and it's usually done, as we said, through the primary care providers or the hospitalists who are the primary care provider in the hospital setting. Specialist palliative care comes into this resource intensive, support, which is resource intensive, supports patient with complex care needs, and is provided by our specialty trained professionals in multidisciplinary teams. Now, I think as I earlier said, the reason, or let's see, to meet economic challenges and enable a just and efficient allocation of resources, palliative care, including funding systems for palliative care, should be based on patients' needs rather than diagnoses or prognosis as currently in most countries. So this is just, a line that I threw in there just to kind of help with background uh, of palliative care needs for the patient. So now we come to the complexity. So in complexity, we have these, let's describe the complexity of the patient and the system as follows. Number one, to grade the nature of patient situation and the extent of the resulting care demands. Patients, symptoms, care situation, family needs, and other factors are often described by concept of complexity. So this is basically the patient situation. Then we come to system thinking. It provides a framework. The whole system thinking, provides a framework in which complex problems and their solution can be located and supports an in-depth understanding of complex problems. Then dealing with complex problem needs a certain method of problem solving. Then to differentiate patient in need of more resource intensive palliative care versus patients for whom a generalist palliative care, approach is sufficient. So kind of have to define complexity. Then we should have a baseline, system in place to help with our patient cares. Then there should be a way of kind of, algorithm of problem solving with these complex patients, and then to differentiate who needs, which patient needs to go in which direction for their care needs. All right, okay. Now, complex adaptive system. So what is it? It's a collection of individual agents with freedom to act in ways that are not always totally predictable and whose actions are interconnected so that one agent actions change the context for other agents. Characteristics of a complex adaptive system are concept of adaptation, emergence, self-organization as well as the concept of attractors and contextuality. Um, Now there are three types of problems: simple problems, complicated and complex. And the complex problem, kind of can include both simple and complicated. And one thing about complex problem is that it's not static, it changes. So basically, we have a team here, and the team members are the agents, and each agent kind of, like our providers, like, physicians, nurse practitioners, social workers, all of us interact, and each of us have a say, and that kind of, leads to approach the goals of the patient in collaboration. And then, as we said, that the complex problem of our patients are kind of not static because they change as our patients, they might get better, they might get worse. So the complex, problems will kind of move on, or they kind of fluctuate. All right. Then, so the complex adaptive system, of if you do the palliative care situation within the complex adaptive system theory, they have three subtypes. And these are patient agent, the other one is system agent, and then the third is team. They are, in addition to those, environmental factors which interact with care situations from outside the system. And then there are agents within the subtypes, and subsystems and subsystem themselves interact on all hierarchical system levels and shape the system behavior of a palliative care situation. So this is basically what I just described in, the palliative care situation, incorporated it as a complex adaptive system, or in that theory. So here what we can see is our, patient system. And our patient system basically has physical subsystems, And then, socio-cultural, subsystem, and psycho-spiritual. So these are basically, if you kind of like physical subsystem, basically, involves physical symptoms, clinical signs. It also involves primary diseases and disabilities, stuff like that. Then socio-cultural subsystem, kind of has the patients, several social agents, which are individuals. And they basically, these social systems, they define the behavior of the whole system. All right, then we have the psycho-spiritual systems. Then next we will go to system team or team systems. So team systems basically, are where us providers come in and basically it's a team of hierarchical level than the patient system or system patient. And it composed of social agents, the team members, and these act upon emotional, cognitive, and social rules. Then we have the social, system for the patient. And basically, the social system, there are, how to say it, this is composed of, as I said earlier, individuals who define the system behavior. All right. Then kind of, it's a short presentation. The conclusion that we come to is that the purpose of this discussion is to provide a conceptual framework and comprehensive understanding of complexity in palliative care. Then the systemic view can help to understand and shape situations and dynamics of individual care situation on hierarchical level. It can support an understanding and framework for development of care structures and concepts. The framework provides a foundation for the development of a model to differentiate palliative care situations by complexity of patient and care needs. So, how I see this thing is that like a solar system, where patient is the center, the sun, and then all the planets revolving around it are the different agents in different system types, the patient system, the social and the team systems. And we are all trying to keep the patient in harmony, or kind of, keeping the patient's needs met. And we don't, with our help, everything, goes in a normal fashion and nothing collapses. So that's how I think, or how I felt when I kind of went over this review. So that's the conclusion. Any questions or comments?
Thank you, Dr. Sabi. One of the questions I have has to do with, so we talked about in the beginning, the two different types of palliative care, right? The generalists and then the more specific.
Yeah.
And if my understanding is correct, and I ask you to help me if this is incorrect, the work of this group really are the specialists in palliative care. And then the generalists would be maybe the hospitalists or the attending doctors who have the goals of care conversations without the assistance of the specialists. So then my question would be, it seems like every case is complex and that every case would benefit from the specialist. So I'm curious of examples of cases that really don't need, especially cases in the hospital that don't need the specialist.
All right.
What
So,
would be an example?
all right. So I think, there are two parts to it. One is the patient themselves and their complexity. And then the second part is the provider themselves and their experience and their ability to handle that, not only the palliative care part, but the end of life uh, situations. So let's see, I'll give you an example, even not in the hospital setting, but in a clinic practice setting, and in the ER. So one of our patients who is elderly, we know that they're kind of coming more towards end of life, and they presented to ER. They were brought in by the daughter. Daughter is the activated POA, so ER evaluated them, and then the discussion was with the daughter, are we going to hospitalize the patient versus is there anything else? So what they did, or they want, kind of just comfort care. So what they did, the ER doctor called the primary care provider, and the primary care geriatrician, he was very familiar with the patient and the daughter, which is the family and the healthcare, kind of proxy. So the decision was made then and there that she's going home with hospice, to which, it took a little time, out of the primary care doctor's office, and how they have to see the clinic patient. It took a little time out of that, but the decision was made, and it was without any need for bringing in palliative care or even hospitalization. So I think most of our patients that I've seen here in palliative care, they're really complex, and they benefit from our providers in all the team work, including, physicians, nurse practitioners, our social worker, our chaplains, So, yeah, so that's how I would take it, or, answer the question. I hope it helped.
Yes, thank you. Yeah.
You're welcome.
And I would add to that, Ruth, that the description that Ozma described was a primary care provider who was able to intervene. And so there's a relationship there. And so sometimes our role can feel different here in the hospital, where patients are with total strangers, as opposed to people that know them well out in the community. Yeah.
Thank you.
Yeah. I wanted to add one other comment before I mute myself again. As I'm listening to you talk about the complex adaptive system, a lot of it seems to focus on the importance of relationships between these individuals, just like the importance of the relationship between that PCP that was able to help that patient get hospice. And I've noticed that the quality of the consults here at our hospital really have improved a lot over the last year. They don't feel so much like triggers anymore. It's a lot more about judgment. And I think it's not a coincidence that there's been a lot more of a relationship and collaboration between the palliative care team and the hospitalists over this last year, especially that Pooja has done. And I think that helps with the relationship, and it helps also us each learn from each other. So that way the teams are appropriately using us for those most difficult cases where we are a limited resource, but we can be the most helpful, the most bang for our buck.
All right. Yeah, thanks. One thing I felt is that, and what was also in this paper, is that we should kind of direct or we should, look at the needs of our patients, not based on their diagnoses and prognosis, but, actually, well, let's see, the patient should not be looked up just, oh, this is their diagnosis, this is their prognosis, that's what we're going to do. But actually, we should look at their actual needs, and complexity. So does that make sense?
And that only happens when I think the teams that are on the forefront, which is not us, right? It's the hospitalists, when they feel confident about what it is that we do and don't do, what it is that they can do and they can't do, how confident they are in their own skills. And I think that all circles back to the same thing again. It's all about relationships and having that rapport so we can teach each other those things.
You're right. And what I felt in my practice so far, or, learning during this fellowship, communication, communication, communication. That's the key. That's how I would say.
Hey, it's Katrina. Kind of, I guess, Ruth, to speak a little bit to your question, and then to piggyback off of the comments that were just made. I know I had a situation recently where we received a consult, and unfortunately, the circumstance was just that no one had really been able to get in touch with the power of attorney yet. And so we got consulted, but there hadn't really been any discussion yet. And before we saw the patient, the hospitalist was able to get in touch with the power of attorney, had a great conversation, messaged and said, you know what, we don't really need you because we have a plan in place already. It was a very complicated patient with a lot going on. But again, to just speak to that communication piece, it's, sometimes it seems like, oh, wow, we're really going to need palliative on this one. But when there is a good, a good firm conversation had, depending on the other providers, let's say comfort or skill with that, then we maybe aren't needed, even in a really complex case.
Yeah. That's a great example. Thanks, Katrina.
Thank you.
Asma, can I put you on the spot with one last question before we
Go
enjoy
ahead.
a beautiful weekend? So you are a geriatrics fellow.
Yes.
And I'm curious, now that you're well into your fellowship, now that you've spent a lot of time with us as well in palliative care, what in your opinion, what's one of the biggest similarities between a geriatrician and palliative care? And also, what's one of the biggest differences that you've noticed?
All right. So, okay. So let me think a little bit, but I think the similarities are, one is that, we deal with complex patients. And then we deal in being a geriatrician, we also do a lot of palliative care discussions with the patient and families. We also deal with the end of life hospice, decision making involving the patients. And sometimes, we end up following those patients who are at home hospice. So these kind of, are definitely the similarities. The difference, I would say, is that we also have, as a geriatrician, I have the opportunity to treat my patients, and kind of follow up for their chronic illnesses, even prior to they reach that palliative care. Try to, also take care of them, the other individuals whose medical histories are not that complex. Try to keep my patients as healthy as I can over a period of time, prevent the falls, and kind of follow them over years for their kind of, needs. So this is kind of more like, I would say, a treatment part or kind of preventative part, which is there in geriatric practice, which I think is not a part of palliative care.
Gotcha.
Does that make that answer the question?
Yeah, it's nice that you get a chance to be more upstream and have an opportunity to form potentially years of relationships where we tend to be, even though we don't want to be so far downstream, we tend to be a bit farther downstream. So, all right. Well, thank you, Asma. We really appreciate having you on today.
Oh, thank you for the opportunity. I enjoyed it.
Thank you, Asma.
Thank you. Everybody has a great weekend. Thank you.
All right. Bye. Take care.
Bye. You too. Thank you.